start with the overview. So I'm going to talk about hormone receptor positive breast cancer with a focus on systemic therapies. First, I'll be defining the subtype, and then I'll talk about early stage and metastatic disease and a brief discussion about future options. And I'm going to focus more on the endocrine therapies and targeted therapies and less so on chemotherapy, but we'll talk a little bit about the patients who might benefit more from chemotherapy with the hormone receptor subtype. So hormone receptor positive breast cancer is the most common subtype, and the ER positive HER2 negative group makes up around 74% of the total. And this is grouped into the luminal A and luminal B. The traditional way of comparing luminal B to luminal A is to say that luminal B has a higher proliferative index, generally higher grade, 2 or 3, and in the 2014 St. Gallen consensus, it was a KR67 that was delineated the difference. However, the KR67 has been shown to be quite different between institutions, and so it is not reproducible. So KR67, I think, is quite a difficult marker to use and has been superseded by other genomic markers. Luminal B may include HER2 positive or negative as well. You can see on the right-hand panel here that there is a difference in incidence according to age, with the estrogen receptor positive HER2 negative group making up a smaller proportion of the younger age group and a higher proportion of the older age group compared with triple negatives and HER2 positives. And you can see that the HER2 positive ER negative tends to occur a little bit later and is the smaller subgroup. We're going to focus on that most common subtype, and we can see that endocrine therapy has been the biggest impact on disease-free survival, preventing tumour recurrences in a large proportion of patients. So we have the Oxford overview from 2005 demonstrating that compared to control or no endocrine therapy, there is a significant reduction in breast cancer recurrence, and that extends out to 15 years. And this overview looked at 5 years versus no endocrine therapy. And you can see that there's an ongoing separation between those curves, indicating that the endocrine therapy with tamoxifen in this instance helps to prevent breast cancer recurrence beyond the time that it is completed. I think that's very important, and I think a big part of that is the reduction in the rate of recurrence of new primary breast cancers. And so there's a substantial benefit just with tamoxifen of at least 1/3, or about a 30% relative risk reduction of recurrence. Breast cancer can recur in the estrogen receptor positive subtype many years down the track, and it can recur up to 20 years or even later as a metastatic recurrence. And therefore, the role of endocrine therapy in preventing later recurrence is quite important. Now, we've come to a more recent meta-analysis of the Oxford overview group again, looking at the cumulative recurrence after aromatase inhibitors or tamoxifen. And you can see that at 5 years, there's a 3.1% difference, which is clearly not as big as that between tamoxifen and control, but it is an additional gain. Out to 10 years, there is an ongoing benefit to an aromatase inhibitor, reducing the rate of recurrence, but that the curves do not separate further. So there's a 3.6% overall gain in the recurrence between tamoxifen and aromatase inhibitors. Looking at overall endocrine therapy and systemic therapy of early stage breast cancer, I'd like to talk a little bit about the absolute versus the relative benefit, because if you have somebody who has a low risk early stage estrogen receptor positive and hormone receptor negative breast cancer, they may have a small recurrence risk. And that recurrence risk is real, but they derive a relative 30% reduction in their recurrence risk. But that might only be a small absolute benefit because they had a small recurrence risk overall. And if they have a very good prognosis, then you can't benefit them a great deal more by reducing their recurrence risk. Whereas if they have a large, high-grade lymph node positive cancer that is of a higher recurrence risk, then if you reduce that risk relatively by 30%, then you're going to see a greater absolute benefit. And that patient is going to be more likely to experience a recurrence still, but their relative improvement will be great. So for the early stage, low-risk patients, my view is that the toxicity profile shapes treatment choice to a greater extent than the absolute tamoxifen and the aromatase inhibitors to all be very similar, whether anastrozole, letrozole, or exemestane. There are a number of large adjuvant trials, of whom I've selected a few. The more recent ones, ATOM and ATLAS, looked at 5 versus 10 years of tamoxifen, ATAC, anastrozole versus tamoxifen, Big One 98, looking at letrozole, and all of those have demonstrated gradual improvements in the overall recurrence-free survival of ER-positive breast cancer. I consider 5 years to be the minimum, but then I will give patients additional treatment for 7 or even 10 years, particularly if they have a larger tumour of T2 more than 20 millimetres or lymph node positive. But all patients appear to derive a benefit from endocrine therapy, whether they're good prognosis or poor prognosis patients. Now, I use the Predict online calculator to give an indication of the prognosis in estrogen receptor positive breast cancer, and that also tells us about the incremental benefit of endocrine therapy, plus or minus the zoledronic acid and chemotherapy. Now, I would not use the Predict calculator for HER2 positive disease, just as an aside, and there's been some data demonstrating that that is not accurate. I also look at the recurrence risk between years 5 and 10 with the CTS5 calculator, and you can see the URL there on the screen. That gives an indication about whether it's worthwhile and whether there's a poor prognosis for patients who are at year 5 and whether they might consider going on to 10 years. I think the toxicity profile, again, ties into this quite a lot because those patients have sometimes formed opinions about whether they're going to continue on. Some are very keen to continue despite having low-risk disease. Others can't wait to stop their endocrine therapy, and some may have stopped it already because they have significant toxicities. The toxicity profile of endocrine therapy you will all know quite well, with aromatase inhibitor-induced arthralgia and bone mineral density loss being the most significant toxicities. The menopausal symptoms shared between both tamoxifen and anastrozole, and the tamoxifen-induced toxicity, albeit uncommon, of endometrial cancer only in postmenopausal women, and venous thromboembolic disease. In terms of premenopausal patients, there is the SOFT and TEXT trials, and these looked at, in combination, patients receiving standard care at the time of tamoxifen and whether adding in ovarian function suppression to tamoxifen would be more effective in terms of disease-free survival and overall survival, and whether, on top of that, adding in exemestane as a steroidal aromatase inhibitor to the ovarian suppression. Clearly, in premenopausal women, using an aromatase inhibitor alone is not an effective strategy. In fact, it stimulates estrogen and is likely to be worse than nothing at all. So those trials were combined into a large and powerful analysis, and that has demonstrated that there is an absolute gain, particularly in the patients who've had previous chemotherapy, of ovarian suppression above and beyond tamoxifen at 8 years of 5.3 percentage points. So that's an absolute benefit in the disease-free survival. Then when exemestane was added into that, you can see that there's a further benefit of another 3.7 percentage points beyond tamoxifen and ovarian suppression, and 9 percentage points above those patients who received tamoxifen alone. And this bore out in the comparison just between the patients with exemestane and ovarian suppression and tamoxifen and ovarian suppression, with a 4% absolute difference in the combined analysis. Along with these improvements in disease-free survival, which are incremental but have resulted in many, many patients being alive who may not have been alive without them, there are increased toxicities. And that includes vasomotor, things like hot flushes and sweats, genitourinary toxicities, which are substantial, but sometimes patients are concerned about talking about those toxicities, and psychological, so depression, irritability, anxiety, and that ties into their fear of cancer recurrence as well, and can have a substantial impact on these young women and their functioning. Those toxicities do appear to improve over approximately 3 to 5 years, but the improvements are not particularly quick. To work out what patients might need, there have been some trials comparing different durations, and I've selected out a few here. ABCSG 16 has reported recently and compared 7 to 10 years of an aromatase inhibitor and found that 10 years was no better than 7. So many patients, I'm winding back the aromatase inhibitor if they've only been on an aromatase inhibitor to 7 years. Tamoxifen, there is a small additional benefit to 10 years versus 5, and that's particularly in the meta-analysis, which grouped ATOM and ATLAS to those with more than 2 centimetres and or lymph node positive. The sequential treatment is where the 10 years seems to be most beneficial, and the meta-analysis that was done by the Oxford group showed that there was most benefit in those patients who received initial 5 years of tamoxifen followed by 5 years of an aromatase inhibitor, as opposed to the patients who had upfront aromatase inhibitor who did not seem to benefit from an ongoing total of 10 years. In the premenopausal patients, the higher the recurrence risk, as I mentioned before, the greater the benefit. Now, the soft and text data have been put into a step analysis, which includes age, lymph node burden, tumour size, tumour grade, estrogen receptor, progesterone receptor, KR67, despite the drawbacks of that I've mentioned previously, into a composite risk calculator. This is not particularly easy to find online, I would have to say, but the URL is there, and I'm happy to share it with you for those of you who are interested. But it's hosted by Harvard, and you can input the different variables here and come up with a recurrence risk and a potential benefit. And so I'll draw your attention to a patient that I've made up here with a relatively high risk, with a composite risk score of 3. And here you can see that that patient would experience at least a 10% freedom from distant recurrence benefit in absolute terms of adding in exemestane to ovarian suppression. So you can look at that to work out if it's a substantial benefit or not, to assist with decision-making around how intense the treatment should be for patients. Now, with aromatase inhibitor and ovarian suppression, we recommend that it's monthly ovarian suppression with goserelin or triptorelin, not the longer-term preparations, or surgical oophorectomy. And if they are on goserelin or triptorelin, then they should have intermittent testing to ensure that they have suppressed estrogen in the undetectable range. Otherwise, there may be some level of estrogen that could be resulting in ovarian stimulation and breast cancer stimulation. So who should receive adjuvant endocrine therapy? The St. Gallen panel had a deliberation over that this year, and in the top line is the dashes for luminal A and luminal B. And they're the ones who the panel would almost always recommend endocrine therapy. Perhaps not for microinvasion, and it depends on menopausal status as well, which is not outlined here, but the majority of the panel would consider endocrine therapy for anything more than microinvasion, and that includes 1 millimetre or more, and 100% of the panel would recommend endocrine therapy for a tumour size of more than 5 millimetres in greatest diameter. And there's the benefit of preventing distant recurrence as well as preventing local recurrence and new primary breast cancers. I'm going to talk a bit about the Cdk46 inhibitors because I think that that's been quite relevant recently in early stage breast cancer. They inhibit the cell cycle and the transition from G1 to S phase. Now, this is by preventing the phosphorylation of retinoblastoma protein with the cyclin D complex and reduction in the MAP kinase and PI3 kinase signaling pathway. So it prevents the estrogen transcription factor, E2F, and then will reduce and prevent cell cycling, and they help to enter senescence. Now, there are 3 main CDK46 inhibitors, palbociclib, abemaciclib, and ribociclib, and they inhibit CDK4 and 6 at different levels. And that influences the toxicity profile as well as potentially the efficacy profile. They're certainly active in estrogen receptor positive breast cancer, but they're also effective and they're in HER2 positive breast cancer, and we're seeing some signals there. The Monarch E trial has been presented a couple of times now, and in high-risk early-stage breast cancer, which is either lymph node positive and large tumour or grade 3, or high-risk based on KR67 with either 1 to 3 lymph nodes, more than 20% KR67, and they did not fit cohort 2 that you can see, cohort 1, sorry. These patients, there were 5,700 randomized to receive abemaciclib, 150 milligrams twice daily plus endocrine therapy, or endocrine therapy alone. It was an open label over 2 years. And then they subsequently enter into follow-up. Primary objective with invasive disease-free survival. So this is an early stage high-risk breast cancer trial, and it included both women and men pre or post-menopausal, and maximum of 16 months from surgery to randomization. There was a relatively high-risk patient population, and 60% had more than 4 lymph nodes positive, 40% grade 3, and there were 45% had higher than 20% KR67. And so hence my discussion about KR67, I do think it has substantial shortcomings. However, it has significant implications. This follow-up from April 2021, 27.1 months after 565 IDFS events, there were 72% of patients had completed 2 years of treatment, and 90% were off study treatment because some of them had ceased due to toxicity. So 27% overall had ceased treatment due to any reason, 17% due to adverse events, and there were some who'd ceased because of high-risk disease due to the presence of a recurrence. 42% had a dose reduction due to diarrhea, fatigue, neutropenia, or other reasons. And here is the updated invasive disease-free survival. demonstrating at 3 years there is a 5.4% absolute difference in invasive disease-free survival. And if you look at the number at risk, you'll see that there are a small number, only really 500 odd patients combined, that had reached the 3-year mark. And so at this, I would suggest that 24 months with the 2.7% difference is the clinically important time point. And that is still, with many patients still being on abemaciclib or having just stopped it, that we need more follow-up. We are seeing approvals, and the FDA has approved this in the early stage setting in America for patients with high-risk disease with a high Ki-67. There's a 1/3 difference in the risk of developing an IDFS event, and I'll draw your memory back to the tamoxifen overview, which was essentially a 30% reduction. So this is quite important if it continues to become apparent as a difference. I'm going to compare here in this slide the variety of trials that we've seen in the adjuvant setting with Cdk46 inhibitors, Pallas, Monarch E, Penelope-B, and Natalie. And the palbociclib trials are Pallas and Penelope-B. Unfortunately, neither of those have shown any benefit. And Penelope-B did show a benefit initially, but that benefit was lost with time. And I suspect that that's because in the post-neoadjuvant setting, those patients had high-risk disease, and they then had a recurrence that was delayed by palbociclib, but was not prevented entirely, because we're aiming to cure these patients. Natalie, which is using ribociclib, has not yet reported. It's a longer duration at a lower dose than the metastatic setting. Discontinuations were high in Pallas, but we've seen that there was an analysis of the patients who discontinued, and the analysis showed that those patients who discontinued did not have a higher recurrence likelihood compared to the patients who persisted with their endocrine therapy. And there'll be more data on that coming at San Antonio. There's been a meta-analysis of the adjuvant Cdk46 inhibitor trials, which demonstrates that there is a benefit overall. Clearly, Monarch E is contributing most to that, but the point estimate on the left-hand panel shows that it is to the left of midline, favouring Cdk46 inhibitor plus endocrine therapy over endocrine therapy alone, with a hazard ratio of 0.85. And Natalie will be important in looking at that. So overall, in the adjuvant setting, the Cdk46 inhibitors, the follow-up remains short, and there is approval for abemaciclib. Overall survival data are immature, and there are substantial cost implications. There's been no robust biomarker or subgroup to select a group with a greater benefit. Quality of life does appear maintained in this group, and there is an extensive translational research program underway to look at mechanisms for resistance and to identify populations that may experience more of a benefit. In the Pallas trial, it appeared that there were patients who had who didn't have chemotherapy had greater benefit, as well as the node negative, and they're probably the more likely ones to have not had chemotherapy. Genomic testing for the decision about adjuvant chemotherapy. There are 4 main scores. The oncotype score, which is only done in the US, 21 genes, which is prognostic. So, and we can see that for patients with a low recurrence score of 26 or less, that they have no benefit from chemotherapy in the node negative group, according to the TAILORx trial. I'll talk about responder in a moment. Mammaprint, the primary outcome from the MINDACT trial was actually a prognostic indicator. In the high clinical risk and low genomic risk, they were randomized to chemotherapy or not, but it wasn't the randomized comparison that was the primary outcome. And actually, there was a 1.5% lower likelihood of survival without distant metastasis in the patients who did not receive chemotherapy. However, their primary outcome was positive in that the no chemotherapy group still had a very good prognosis of more than 92%. The PAM50 risk of recurrence, that clearly is prognostic, and this is comparing the PAM50 risk of recurrence to Oncotype. And EndoPredict, likewise, particularly with the EP Clin, when you include the clinical criteria as well as the genomic score, it has good prognostic information and not necessarily predictive of chemotherapy benefit or not. So the responder trial is the node-positive population. It actually included women older than 18 years, pre or post-menopausal, estrogen receptor positive, and HER2 negative, 1 to 3 lymph nodes without distant metastases. And then if they had a recurrence score between 0 and 25, they were randomized between chemotherapy and endocrine therapy or endocrine therapy alone. Stratified by menopausal status, which is quite important. If they had a recurrence score more than 25, then they were off study. So 5,000 patients were randomized. And you can see here that the invasive disease-free survival as the primary outcome was no different in the postmenopausal group who had endocrine therapy versus chemotherapy. So no significant difference. And this means that many patients will be able to avoid having chemotherapy with a low Oncotype score. Now, in the premenopausal population, there was a difference of about 5% between chemotherapy and endocrine therapy, even with a low score. And when they stratified that between the low score and the intermediate low score, there was still a benefit in the premenopausal patients to chemotherapy. Now, a lot of the discussion about that has been whether there's been a ovarian suppression effect of the chemotherapy, and perhaps we could just give them endocrine therapy with maximum ovarian suppression, but that is not borne out yet with evidence, and there'll be more trials needed. I'm going to move on to the hormone receptor positive metastatic breast cancer now. And we've seen over the decades, looking at the right-hand panel, that there has been an improvement in the likelihood of cure, likelihood of disease-free survival over the decades. And those patients are living longer, but unfortunately, there are few who are cured. Now, we do see the occasional patient, particularly with HER2 positive disease, that does have a long-term survival. And some who have a complete response and then were able to stop their HER2-directed therapies, but that is much less than 10%. And the majority of patients will unfortunately succumb to their disease. Triple negative is clearly worse, and the hormone receptor positive patients are doing better and better, particularly with the Cdk46 inhibitors. So I'm going to refer to the ABC5 guidelines, which are quite a good resource, and it covers both all of the subtypes of breast cancer, but I will be focusing on endocrine therapy. Now, as initial therapy for metastatic hormone receptor positive breast cancer, and particularly 10% estrogen receptor or more, endocrine therapy is preferred. Now, in the patients with low endocrine therapy, with low ER of 1 to 10%, they should not be considered for endocrine therapy exclusively, because the likelihood is that they will not respond well and that chemotherapy should be considered. So endocrine therapy is preferred even in the presence of visceral disease, unless there is a visceral crisis, which means that there is impending organ damage and that that patient needs a fast response. In premenopausal women, many trials did not specifically look at premenopausal women, and that means that our standard of care is to give ovarian suppression with goserelin or to ovarian ablate, and typically that would be surgically, and then treat in the same way as postmenopausal women and with first-line treatment of endocrine therapy. A biopsy is critically important at the diagnosis, and at least once after initial therapy, maybe at the time of progression on initial therapy or later on, because there is some patients who will have a change in their breast cancer phenotype and may lose lose their hormone receptors, or they may gain HER2 receptors. There's no role for combined endocrine and chemotherapy. So in the first line setting, we have trials looking at aromatase inhibitors plus abemaciclib in this panel, and you can see the Monarch trial, and that shows a clear separation of the progression-free survival curves with a hazard ratio of 0.525 and an almost doubling of the PFS at a 39-month follow-up time point. This also prolongs time to chemotherapy, prolongs time to second progression, also known as PFS2, and the duration of response. I'll talk about the PFS2 for a minute because there are initially some people who are worried that the patients progressed faster after completion of aromatase inhibitor plus Cdk46 inhibitors, but that has not borne out in the evidence, and that there does appear to be longer PFS2. There's no clear subgroup benefit, and we can see that on the right, there's a forest plot comparing progesterone receptor status, tumour grade, treatment-free interval, and liver metastases. There does seem to be a slight benefit to those with liver metastases, progesterone negative, higher grade, and shorter treatment-free interval with abemaciclib, and that does differentiate it from the other therapies, the ribociclib and palbociclib. Ribociclib in the Mona Lisa trial was letrozole plus ribociclib or placebo, and there's remarkably similar findings. So hazard ratio of 0.568, PFS of 25 versus 16 months, and a clear separation of the curve. This is the first to report an overall survival benefit, and you can see now that there's, in the ribociclib population, there is over 5 years overall survival, putting hormone receptor positive breast cancer into the chronic disease category. And again, there's no clear subgroups, looking at the forest plot on the right, but there's no difference between those patients with liver or lung metastases versus not, as distinct from abemaciclib. But you can see that otherwise there's very few differences there, none statistically significant. In the Paloma 2 trial, there's very similar benefit and almost the same hazard ratio again, PFS very similar. And so I think this is quite instructive. All of the benefits are maintained, time to chemotherapy, quality of life. We've yet to see overall survival from this. And there's no clear subgroup based on clinical or pathological criteria that shows a patient population that is more or less likely to benefit from palbociclib or any of the other Cdk46 inhibitors for that matter. So these have been put into a meta-analysis, and there have been, the second line for endocrine resistant population with fulvestrant is very similar. And you can see Paloma 3, Mona Lisa 3, and Monarch 2, and they've all demonstrated an overall survival improvement with fulvestrant and the Cdk46 inhibitors, and meta-analysis confirms this benefit is maintained. And so we can see here there's no clear subgroup population in this meta-analysis, which included all of the Cdk46 inhibitor trials, the major randomized ones. And so by age, visceral, bone-only, number of metastatic sites, menopausal status, endocrine sensitivity or prior chemotherapy, there was no clear subgroup with a benefit. So from my point of view, I think that overall it's the toxicity profile that makes a big difference, and the monitoring profile. You might say that given that Monarch E showed a benefit in the early stage setting, maybe it's a better drug. I think we need a little bit more evidence, a bit more theoretical rationale for that, and we haven't seen a signal of benefit in the metastatic setting. So I still use them fairly interchangeably. And I have a discussion with patients. If they have any contraindications that might prevent me from using one or the other, then I'll use the appropriate treatment. With ribociclib, issues are neutropenia, but very minimal febrile neutropenia. Now, they can experience prolongation of the QT interval, and they may also experience fatigue, sometimes some alopecia. So I was talking about the toxicity profile. Palbociclib doesn't have the issue of QTc prolongation, but does have neutropenia and fatigue. Abemaciclib, not so much neutropenia, but does cause diarrhea, abdominal pain, and fatigue, which tends to improve within the first couple of months. And they all of the toxicities improve with a dose reduction. The dosing of ribociclib is a bit more flexible because of the 200 milligram tablets, taken 3 daily initially, 3 weeks on, 1 week off. But the abemaciclib, I think, is also quite nice in that it's continuous, and maybe that might make a difference in terms of the effectiveness of it, because you don't need a break to allow recovery of neutropenia. The neutropenias turned out to be not so much of an issue, and we very rarely see febrile neutropenia. There's fulvestrant and the other selective estrogen receptor degraders, and that's particularly useful in patients who have become resistant to endocrine therapy, and patients with an ESR1 mutation may benefit most. And so you can see here a flourish plot of a meta-analysis which has looking at fulvestrant versus other endocrine therapies. That might be an anastrozole, exemestane, or tamoxifen. But only one of those trials within this forest plot used the current recommended dose of 500 milligrams, so the first trial. And we've realised that 500 milligrams is the right dose to use, and that 250 milligrams is inferior. So this has shown that fulvestrant is at least as effective as AI or tamoxifen. And there's one trial, the first trial, showing that it is actually better in the first-line setting. There's no benefit to combination use with other endocrine therapies. I'm still using the Bolero-2 regimen. There are some of my colleagues who've found that it's not so effective, and I guess when we've got more and more lines of endocrine therapy, this is a bit more of a toxic treatment, but it can be better tolerated than chemotherapy. And the other thing is that patients who have had a couple of lines of endocrine therapy may be very endocrine resistant and may not end up benefiting so much from it, whereas the Bolero-2 population, they were not so heavily pre-treated. They just had progression on a non-steroidal aromatase inhibitor in either the adjuvant or the metastatic setting. This shows that there's a substantial progression-free survival benefit, but this did not translate into an overall survival benefit. When I do use it, I use dexamethasone mouthwash 4 times per day at a 0.5 milligrams per mil dose. And that's pretty easy to make with dexamethasone tablets, ground up into water, just a 4 milligram tablet, put into 40 mils of water. And I also consider reducing the dose of everolimus initially. The SOLAR-1 trial looked at fulvestrant plus or minus alpelisib, a PI3 kinase inhibitor at 300 milligrams daily, and the primary outcome was the PI3 kinase PIK3CA mutant patients, whilst they did include a little less than half the population with wild type PIK3CA. So you can see here that there's a hazard ratio of 0.65, progression-free survival, which translates to 11 versus 5.7 months in the PIK3CA mutant group. So this was in tumour tissue, but there's a secondary analysis showing there's a benefit in circulating tumour DNA positive PIK3CA mutant patients, which is present in about 30% of the population. The tumour tissue mutation rate is a little bit higher than that, and it's best to test it on a fresh biopsy rather than on a archival biopsy. But you just need to be aware of the risk of rash, stomatitis, hypoglycemia, and diarrhea with alpelisib. That's something that is coming online in the near future. Endocrine resistance, which I've alluded to before, there's a diagram here showing that there are a range of reasons why, whether that might be at the level of the receptor, at the downstream pathways in the receptor tyrosine kinases, or in the stress response and with an apoptotic effect. There is the cofactor of the HER2 receptor and proliferation factors with redoblastnova protein and cyclin E1. And a big one is the ESR1 mutations, as well as PI3 kinase and AKT, as I've mentioned before. So When patients are resistant and primarily resistant and they progress through endocrine therapy, then I would be thinking about using chemo rather than going on to the next line of endocrine therapy. Primary endocrine resistance, defined by the ABC5 group, is relapse within the first 2 years of endocrine therapy in the adjuvant setting, or progressive disease within the first 6 months of first-line endocrine therapy for metastatic disease. And secondary as relapse whilst on endocrine therapy, but after the first 2 years, or within 12 months of completing adjuvant endocrine therapy, or progressive disease more than 6 months after initiating endocrine therapy for metastatic disease. So we can, it's a research tool. We've got liquid biopsies, which is quite attractive, and circulating tumour DNA is potentially useful. It remains a research tool, but it can show a prognostic impact as well as give us prediction of benefit. And here on the right, we have the ESR1 mutations and the change in tumour size. And so we can see that the dominant tumour ESR1 indicates that they're more likely to experience a benefit so it can predict for a treatment effect. We're seeing this now with the alpelisib with the PI3 inhibitors. There's also circulating tumour cells, which are prognostic with metastatic disease, and we have overall survival improvement in patients with fewer than 5 circulating tumour cells, as well as a reduction in circulating tumour cells having prognostic impact. So patients who have more than 5 tumour cells at all time points have quite a poor prognosis, whereas if they have a decrease from more than 5 to less than 5, then they have a better prognosis, which is close to those who didn't have circulating tumour cells in the first place. Monitoring progress, there's been estrogen-labelled PET scans have emerged recently, which can identify metastases with estrogen receptors, and there's useful if there's a differential response or if there's uncertainty about the diagnosis of metastatic disease. It requires an FGG PET as well, so it starts to become a bit complicated in interpretation as well as expensive to do, and so it hasn't been in routine use, at least here in Australia. Not internationally used very frequently. In the clinical trials, there are a range of trials. I've picked out a couple here. There are some oral selective estrogen receptor degraders coming through in the early stage and metastatic setting now, and they're going to be quite interesting. They seem to be fairly well tolerated, some of them, and avoid the need for an injection, which patients really value. There's the FINA trial, which is looking at second-line fulvestrant plus or minus ipatasertib, which is an AKT inhibitor. CAPTURE trial, which is looking at fulvestrant or alpelisib versus capecitabine in the PIK3CA mutant population, and PATINA, which is a combined hormone receptor positive HER2 positive population looking at Cdk46 inhibitors.